maybe we should move on to the next case.
So just to introduce our next case, which will be the last for the evening, and then everybody can finally exit out the door. So you have the graveyard shift, Dr. Gatley. Liz Gatley is second of our new hepatology fellows. She even started, well, at least Sandy started 2 months ago. Liz started this week. So welcome, Liz. Welcome. And over to you.
All right. Food and wine are in your future. We're nearly there. So I'm looking at a group of patients rather than a single patient, and our title is Deepening Epidemiological Insights into Hepatitis C in South Africa. So I won't labor this point. Hepatitis C remains a significant problem globally, with at least 9 million people infected in the Africa region. Hepatitis C, despite the evolution of excellent treatment options, there continue to be new infections, about 200,000 in Africa and 45,000 deaths annually. In South Africa, our epidemiology of hepatitis C amongst our general population isn't completely understood. Our prevalence is that of 0.5%, with an estimated 600 to 800,000 people infected. We have well-recognized key populations, including people who inject drugs and men who have sex with men, with much higher prevalence. They form the basis of most new HCV infections, but it is important to remember that we do have a bimodal age distribution of HCV infection in our country, similar to that seen in the US. Before 1992, blood products weren't routinely screened, and so there is a group of patients who still have chronic Hep B based on that policy. So while we understand how a large number of patients have acquired their HCV, there still seems to be a group where it isn't clear despite extensive history. 2 studies done at the GSH Liver Clinic and published recently highlight this fact. The first is looking at a decade of hepatitis C care at our clinic prior to DAA therapy. And of note, 30% of those patients, despite extensive history into their possible mode of acquisition, we still couldn't identify how they had acquired the hepatitis C. More recently, patients treated with DAA therapy, we still had a high number of patients who we just couldn't pinpoint how they had acquired their HCV. Although unsafe medical practice has been clearly documented as a mode of acquisition in certain patients and significantly in certain regions, it hasn't been documented as a very significant mode of transmission in our country. So our story begins in also the Eastern Cape, province of South Africa. One of the ID physicians working at a tertiary referral hospital there noted that he had seen a number of patients on ward rounds who had been admitted with cirrhosis who had screened positive for HCV. They'd mostly been labeled alcoholic cirrhosis, and HCV screening was done just sort of for completeness sake and to rule out any other cofactors. None of these patients had obvious risk factors for HCV acquisition, and on further inquiry, he came to understand that they all came from the same rural town. This obviously piqued his interest, and he decided to delve a little deeper and phoned a friend at the local hospital in that area asking for assistance. He also then contacted the liver clinic, spoke to one of our hepatologists in order to try and set up a program that might benefit these patients in terms of treatment. So screening was undertaken by examining the National Health Laboratory records between January 2015 and January 2018. All patients from that particular area who had screened positive for hepatitis C were attempted to be traced by the local hospital, particularly those who hadn't had confirmatory testing done. So 67 patients were found via screening of these lab records. 49 were untraceable, even through the local clinic and the local hospital. Only 18 patients managed to be traced. 5 were already deceased, cause unknown, and 13 were found to be alive. 12 of those patients were confirmed to be viremic. During this entire process, 9 new patients were also then identified from the same region. And so this gave us a group of 21 patients with HCV requiring treatment. So the intervention was relatively simple. The patients were seen in 2 outreach visits at their regional hospital unless they were already following up at the specialist ID clinic. Consent for inclusion into the study or this cohort was taken in a language of their choice, and then an extensive confidential history was taken, trying to look into all possible transmission risks. All of those questionnaires were administered by the same ID specialist, and then a full clinical examination, including FibroScan, was done. So the baseline assessment investigations included HIV screening for those not known to be positive, hepatitis B surface antigen screening, and then baseline renal and liver functions. Hepatitis C viral sequencing was done to try and so that we could see what genotype these patients were and perhaps get a better understanding of how they might be related. Point of care testing was done with the FibroScan to assess liver stiffness as a marker for liver fibrosis. Cirrhosis was classified according to the Child-Pugh system. So these are baseline demographics of that cohort of patients. I think the things that I want to highlight here are, 1, the median age of 64. That's significantly higher than what we saw in the key population study done 2017-2018, and higher than the mixed cohort of patients seen at the liver clinic. Of note, there were 2 genotypes identified, genotype 1B and 5A. All patients, so the 5 HIV positive patients were known to be HIV positive prior to us enrolling them in this intervention. They were all on ARVs and all virologically suppressed. None of them screened positive for hepatitis B. And then the last thing I want to point out is the very high rate of significant liver fibrosis and cirrhosis. So 42% of the patients had significant liver fibrosis. Sorry, this essentially is just showing you each patient's history in terms of their comorbidities. Hypertension was a significant comorbidity, but then looking through each of their histories, trying to find a risk factor that might explain their hepatitis C acquisition. So none of the patients admitted to current or ever previous injecting of drugs. 3 had had transfusions. They were all pre-92, and those were related to peripartum hemorrhage. 2 had tattoos. Some had a history of surgery or dental procedures. But the one thing that linked them all was they had all, except 1, noted a history in the preceding decades of attendance at the local clinic, and all remembered receiving some form of parenteral therapy there. This is the phylogenetic tree that was constructed. So you can see our patients in red. They are the genotype 1B and 5A, and we have Dr. Smuts who can speak to that further after this. So at the end of this, we were wondering, could this cohort of patients be explained by possible unsafe medical practices? We think so, based on the older age. As I said, in the key population study of 2017-2018, the age was much lower. In our mixed cohort at the liver clinic, the age was also lower than the median age of 64 seen here. They had significant fibrosis scores, 42% of them, F3 or F4. There was a significant lack of risk factors in many of the patients, and then the clustering of them in this phylogenetic tree suggests a common source. Just briefly, the intervention was relatively simple. They were treated with pan-genotypic DAA therapy of cephalosporin and diclatosphere. They were given a 12-month course unless they had cirrhosis. All but one patient achieved SVR following the initial course of treatment. The single patient that failed was successfully retreated with a new regimen. One patient had side effects, GI side effects, and was switched from diclatosphere, but everyone else did very well. So our take-home messages are just that we are concerned that this could be the first documented cohort of patients that possibly acquired their HCV from unsafe medical practices many years ago. It's unlikely that this would be the only cohort. It is a reminder that we always need to critically evaluate each patient that we see, although almost all of them admitted in the ward were initially labeled as alcoholic cirrhosis. HCV was clearly a significant factor in their liver impairment. It's also clear evidence that a relatively low-key intervention can be highly successful, and we can use online resources to gain expertise and disseminate it into, for example, rural parts of our country. Final note is that further patients from the same region have since been identified and have also subsequently been treated.
Liz, thank you very much for eloquently presenting the data.